Next, we are proceeding on to the panel discussion on rhinology and anterior skull-base surgery, with focus on complications of FES and reconstruction of skull-base defects, which will be moderated by Dr. Vinod Felix sir from Kerala. Dr. Vinod Felix sir from Kerala, he's a consultant at KIMS Health, Trivandrum. He's also an invited faculty for more than 25 international and 60 national conferences. Next, I invite the esteemed panelists onto the stage, which include Dr. Hans Rudolf Breiner sir from Switzerland, Dr. G. Sundarkrishnan sir from Chennai, Dr. Narayanan Janakiraman sir from Trichy, Dr. Parnitharan sir from Chennai, Professor Dr. M.K. Rajashekhar sir from Chennai, and Dr. Ravi Shankar sir from Lucknow.
Good morning, respected senior members, my teachers, Mohan sir, all the invited guest faculty, and my dear friends. And thanks again, my dear friend, brother Naren, for this wonderful opportunity. So let us straight away start without wasting much time. And this is almost like the continuation of the previous talk. I think you would all agree that a smooth sea never makes a skilled sailor. So we all had our part of complications, and that's a similar quote from the Tirukkural. I don't know if they told you that Tamil is one of the most ancient language. Did they tell you Tamil is one of the most ancient language and probably one of the oldest language? And for each and every quote, we have a similar quote from Tirukkural.
Oldest language.
So let us have some case scenarios and we'll run through this, right? So here is a young male, like 35-year-old male. 35-year-old male, chef by occupation. He comes to a ENT clinic with nasal block. And they did some nasal endoscopy. They found some deviated nasal septum and some sinusitis on endoscopy. No CT scan done. Patient undergoes probably a sinus surgery on right side and a septoplasty. So 8 months post-surgery, patient comes with seizures. He goes to a neurologist. They start him on Levi-pill. And after another 2 months, he goes to an ENT surgeon for nasal block. So that's, when they put the endoscope inside nasal cavity, they see a nasal mass there. So that's a case scenario. So let me start from this end. So your comments on this case.
It looks like a skull-base defect with a prolapse of the brain matter. Looks like an encephalopathy. Encephalocele.
Okay. So have you ever seen a post-septoplasty or post-FES CSF leak meningocele in your career? Have you seen patients with a post-septoplasty or post-FES meningocele CSF leak coming to you?
No, I haven't seen it. Of course, it may happen if you are very high, and it's also described to have even anosmia after septoplasty, but that you create an ongoing defect with arachnoid or encephalocele, I've never seen that so far.
But no, can this happen after a septoplasty? Can you get a CSF leak after septoplasty?
You have to be very aggressive in your septoplasty.
No, so because I know one person who caused that. I think you must remember him.
Yes, sir. Yeah.
In 2007, one of your postgraduate students.
He did. Yeah.
He's standing before. It's me actually. So this has happened to me once when I was a PG student. I was doing.
So early stage used to have, but nowadays we are all good in endoscopy.
So I remember I was just actually avulsing the nasal septum like that and twisting it off, and there was a CSF leak. But
under old people, if you push middle terminate forcibly, medially, that time we will get.
And you lateralize the terminate. But we had a very good teacher. He covered me up, and that's probably why I'm here before you to present all these complications and you're an expert lecture, right? So how do you prevent, in your experience, how do you prevent the CSF leak in septoplasty? What are your tips for the youngsters here?
Doing septoplasty, I always do in the endoscopic guidance. So I teach my students don't go above the attachment of the middle turbinate. So if you are going above the attachment of the middle turbinate, you are likely to cause these complications.
Okay.
Those are important things. So while removing the bone also, you have to have good instruments so that you can punch and not
It cut it.
ovals.
Yeah,
Yes.
not ovals, right.
So that can cause defect in the cubiform plate.
And Ravi Shankar, I think I will ask you another question. Why do you think that this patient did not have a CSF leak but straight away came with seizures? How do you explain that? Such a large defect, there is no
Yeah.
CSF leak post-op.
So probably the frontal lobe herniation here, that is a lesion. That is a most common factor here.
You mean the brain is blocking
Yeah,
the
it's
CSF
not
leak?
simply meningocele, it's a meningoencephalocele.
Okay. Now, coming to the next question. This patient actually is a chef. He is a chef in the Middle East. Right? There is a septal perforation. This part of the flap is actually gone. There is no viable hard flap. How do you want to go ahead? Because he is a chef by occupation. I think I'll come back from this end. He is a chef by occupation. There is no viable hard flap. Huge meningoencephalocele. How do you want to repair this?
Me? So,
I think you can from.
So the defect is very big, as well as the herniated part of the brain is also looks huge. So only anterior transcranial approach will be the better for this type of disease.
Dr. Brunner, he is a chef. So transcranial, I think, carries a risk of loss of olfaction.
Well, I think olfaction in this case is not the main prime issue, but you have to save the patient from meningitis, from more seizures. I would like to have an MR to see what the brain tissue does. The defect is not very large, and even if you may probably not have a nasoseptal or hadad flap, it should be not too difficult to close it. So in this case, I would go for a sphenoethmoidectomy, then to prepare the defect, and I will probably, if the lesion is below 2 centimeters, I would probably rely on fascia and then a free mucosal flap. If it's larger, I would go for fascia lata in order to reconstruct the defect.
Any difference
In this case, so meningoencephalocele, we can cauterize it. It's a dead brain tissue. You can cauterize up to the base. You can see the dent. If the dent is less than 2 centimeters or more than 2 centimeters, we can use septal cartilage, then close it. Then, as usual, fat, surgicel, gel foam, and thistle. It might close.
Any different opinion? Or do you all agree with that?
Yeah, like you told, the procedure like shrinking the brain matter and exactly defining the defect is important. And the size of defect also should be considered which material you are going to use. So I would prefer a cartilage or a 3 to 4 layers using fascia, cartilage, fascia again. And the middle turbinate also can be rotated and to give additional layer of support.
so since you mentioned that the chance of adult flap is less possible in this case, but the defect seems to be very large, probably more than 1 centimeter. The vascularized flap will help in better healing. So I prefer in this case, because based on the location, I can go for the middle turbinate flap in addition to the primary reconstruction.
Okay, sorry, let me come back. So I do agree with all of them, but this is what I did actually. So we are now cauterizing, as all of you told, we can cauterize the meningocele, we can shrink it to the base and find the defect. Yes, goes. So we are actually cauterizing the meningocele. We shrunk it back to the base. Oh, this is the other piece. Sorry. So we are measuring the defect, and that's a duragen going in. So we generally use a lot of duragen nowadays. And then we did the right side Caroline's window. That's the front. Can we switch off these lights, please? In fact, we took the pericranial flap and we are taking it inside. So that's a pericranial flap coming through the frontal sinus. It's an endoscopic picture. That's a hole here in the anterior aspect. So we covered this pericranial flap pedicled on the supratrochlear vessels. And we preserve the middle, we preserve the olfaction completely on the other side. I generally make a smaller hole, but a neurosurgeon is very particular to make a bigger hole because they don't want the pedicle to be compromised in this hole. That's actually just a like 5 millimeter hole there. On through that. Sorry. And that's a flap covering the defect very beautifully. Right now, let me come back to another case. It's actually from the literature. This actually is a case of balloon sinuplasty. Post-balloon sinuplasty, and you have this CSF leak. Who wants to take this question? Anybody volunteering for this question? How do you want to tackle this case? Post-balloon sinuplasty.
So I think a leak is from ethmoidal labyrinth, no?
Yeah, there is a CSF leak, but
Yeah, ethmoidal labyrinth.
so you find a CSF leak in the post-op period. How do you go ahead? You wait or you immediately intervene?
See, for me, the iatrogenic cases heals on, even trauma cases heals on wound. If it is due to primary benign intracranial hypertension or any other cause meningocele, we have to close it. For this case, we can wait for 6 weeks with Gardinol, then acetazolamide, 6 weeks. Then still it is not treated, still the leak is there, you have to go for closure.
Sir, but the problem is that there's a tension pneumocephalus.
You have to do it, nothing, no other
So
alternative.
that's the thing. We generally wait, but then you must also keep in mind the possible tension pneumocephalus. Have you seen such?
So this is a concern because the patient probably developing a tension pneumocephalus. We need to intervene in these cases, otherwise.
Really, because I have seen cases, see, you have somebody doing the FIS and there's a CSF leak. They consult some other surgeon somewhere who is a good skull-based surgeon, but they'll say, iatrogenic, you wait. But they're not seeing the true picture. The patient has a tension pneumocephalus and then the patient can go.
I think immediately do the results also are good, and you save the patient from having meningitis extra.
Okay. I think before I come to, I'll come to case because I think I got time. So case 2, it's another case. A 45-year-old patient, it's all last week's case actually. 45-year-old patient, post-trauma, has a traumatic optic neuropathy. Day 1, day 2, the patient is sort of sedated, pupils dilated. But once the patient becomes stable, the vision is normal on right side. So that normally vision is normal now, but the patient has a CSF leak on day 6. It persists beyond day 10, and there is a meningitis in between. Right? So this is the CT scan. So traumatic optic neuropathy right side, which but their vision is normal now. There are multiple fractures. There is one doubtful fracture there. That's a fracture there. Another one there. Another fracture there. There is another fracture just close to the optic canal. There is a fracture on the other side also. So, how do you want to go ahead in this particular patient? There's a clival fracture on clival recess also. So, multiple fractures. Multiple fractures, history of right traumatic optic neuropathy. Pupil on right was dilated, but now it is normal. Now the vision is normal. Had a meningitis, CSF leak persisting beyond day 10.
So any CT cystography is available?
Sir?
Any CT cystography? Because
No.
multiple
So
defect
we-
is there, but which defect is
So you want to do a CT cystography?
mainly to see which is the fistula is still there.
That's a good idea, but a history of meningitis will.
Anyway, we need some sampling for CSF. At that time, we can do CT cystography to look for which fistula is there.
That's a good suggestion. So, yeah. Any other ideas? Any other comments?
You have to treat the meningitis, wait for 1 or 2 weeks.
No. The meningitis is almost settled. Almost settled.
Mostly some,
So when we are operating, the patient had some mild fever, but it is fit for GA.
you said it was due to accident,
Post-trauma.
post-trauma. So neurosurgeons and all, they feel that it will heal spontaneously if you wait for 2 weeks. So
Yeah,
even
that's another controversial question. Actually, we used to have this thing like we wait for 2 weeks, but now in CMC below they are doing a study like they compare patients of CSF leak for whom they waited for 2 weeks and for patients who operated immediately. The patients who underwent repair beyond 2 weeks, they had a meningitis for 1 or 2 years post follow-up. There were even mortalities. So they say that the delayed closure, even if it happens, the strength of the closure is not good, and that can lead to. That doesn't prevent from meningitis.
that's what I'm telling. You have to tackle it immediately. The neurosurgeons will ask to wait for 2
But
weeks.
still, we wait for 7 to 10 days. But different schools of thoughts are there. But
When I may give a comment, I think we have two issues here. We have the optic nerve neuropathy, and we have the CSF leak, which was leading to
but the vision is normal.
meningitis.
Vision now is normal, sir.
So we have one major problem that we have to look for, and this is the CSF leak. And we are not completely sure which is the symptomatic leak. We have several fractures, and we had a meningitis, so we have to care about it. If the patient is recovering from meningitis, then we can go in. Maybe we need another imaging, maybe an MR also here.
Patient recovered from meningitis.
Is recovering,
Yeah.
but we need to go in.
CSF leak is persisting.
Yeah, we need to go in and look where the CSF leak comes from and repair it. It's just a basic principle. CSF leaks of the anterior skull base may heal by itself, but there is always a risk that we have recurrent meningitis even after 10 years. So it's the exception that it will heal without surgical repair. So we have to go in, we need to wait for the right time, and then we have to go in.
So, one suggestion, suppose a CT cystogram, we cannot do it. Okay, so mild fever is there, Felix.
Yeah. But
So, can we do CT cystogram as he suggested?
we can do, but then the history of meningitis.
So, you don't want. So, okay, so you can
go for
state.
a different option. That's it. We have another option like we give the fluorescent.
So, right, you don't want to do. So, then straight away go for closure, endoscopic closure.
Yeah, that's what we are doing actually.
Right.
Now let me come to the next question based on this video. So this sphenoid sinus, that's the optic nerve. That's the optic nerve, and you are seeing the leak just medial to optic canal at the level of the MOCR or the lateral tubercular stud. It's actually coming from underneath the optic nerve. It's a very strange site for a CSF leak. That's the optic nerve. That's the optic nerve. That's the optic nerve.
So you gave fluorescein.
Sir?
The yellow color, is it fluorescing?
It's fluorescent.
Yes, yeah.
It's, so that's a CSF leak coming from undersurface of the optic nerve. And that's the yellow CR is here. This yellow CR, that's a MOCR. So the challenge was patient we don't want to maneuver much around the optic nerve. I just putting an overlay graft.
Can I have one?
Just watch the video. I'll come in. I'll come to the question thereafter. So that's a head flap, right? Just an overlay grafting. Now my question is, see, we try to put a graft onto the defect. Do you want to do that in this particular case with a traumatic optic neuropathy, or you'll do the same thing?
No, whatever you did, it's a right thing. We never expose further. We just draw the area and then we place it. Okay. The most important thing when you deal with this kind of spinal fracture,
Yeah.
before touching these cases, we have to go for a CT angio quite often.
Why? I think he told something about CT angio. Anybody want to take that comment? Why did he tell about CT angio this particular patient?
Mainly to look for any CCF, carotid cavernous fistula, so that type of injuries we have to confirm. Pseudo.
That's a very good comment.
It's very quite often because we have encountered about 3-4 cases, all of the same type of fractures. It's must actually.
That's true. Even we have cases like what we thought like as a fungal sinusitis or sphenoid sinus, but it was actually a pseudoaneurysm. So I think I'll skip this case and come back to the question from the textbook. So coming to Narayan's textbook, some complications from the Narayan's textbook. So let us start with this particular case. Watch the video, we'll have the comments there. It's actually a case of inverted papilloma. So that's the frontal sinus, right side. Watch the video. Lamina papricia, supraorbital cell. See, clearing the disease from supraorbital cell can be a bit tricky actually sometimes. So that's a disease being cleared from the supraorbital cell. That's a lamina papricia. See that getting into the gutter can be really tricky, and I do it a different way, but then everybody has their own techniques. And now there's a bleed. That's the artery. So now the surgeon is palpating the eyeball to look for the pressure, and he's going with immediate orbital decompression, medial orbital decompression. And you can see the cauterized artery there. Now can I come back to the question and see, you are seeing an intact artery, and I don't think it really retracted inside. So how do you think this patient had an orbital hematoma? From the image I am seeing an intact artery. You can see that. Ravi Shankar, I think you agree, right? You can see an intact artery there.
Maybe before you clipping it or cauterize it, some amount of blood would have drawn in,
Okay, maybe that's possible.
would have gone into the orbit.
Yeah, that's a possible thing, right? So, now second question, see that clearing the disease from the supraorbital gutter can be a bit tricky, and when you use a deep breath, you always carry a risk of injuring the artery. Is there a better, you do it a different way or you do the same thing? Because I generally use a diamond birth there, or maybe a curved suction tip.
The direction of cutting edges is very important. When you're dealing with the anterior fovea, the cutting edge always faces towards the frontal sinus. When you're dealing with the posterior fovea, the cutting edge is away from the anterothmal. This is the most important thing.
You mean
the cutting edge. So that's why
but
in
you
ZOMED,
have the disease in the supraorbital, it's towards that gutter, towards orbit.
yeah. So in ZOMED, we have the guidance of the arrow. Right? When you go for a supraorbital, you can this kind of case because this artery is in the mesentery. Before dissecting the supraorbital area, you need to decompress the lamina papyracea, transpose the orbit, and then you do the
Okay,
debride.
got it. Any different comments? Have any one of you seen this case in your experience? Have you ever encountered an retrobulbar hemorrhage? I think the first chapter was, the textbook was from you, right?
Well, I also added a chapter in this textbook, chapter 1.
Chapter
and
1, I read
I
that.
had also inverted papilloma, bleeding from the anterior ethmoid, and I could control it, but I had hematoma. However, I was taught not to go for the artery, so we did a lateral cantotomy and cantolysis. Bleeding will stop by itself, so we let the patient wake up, lateral cantotomy, cantolysis, and so bleeding may happen even though when you coagulate it just by gentle retraction, and this is enough. You don't need a lot amount of blood to raise the intraorbital pressure. You need maybe only 1 or 2 milliliters. And so it's not the blood, it's the pressure. And bleeding will stop by itself because the orbital fat has some compartments, so it will stop by itself. So I was taught not to explore the bleeder in the orbit, just relieve the pressure, let the patient wake up. I don't even go routinely. I have had 2 or 3 cases of this similar. I don't even go for medial decompression, medial orbital decompression. It's probably not absolutely necessary.
Yeah. Yeah, I agree with him. So the problem with these cases are the pressure-induced optic, optic and artery vessels compression and artery compressions. The immediate effect is that the pressure itself, intraocular pressure itself stop the arterial bleeding most of the time.
Yeah,
the main aim is to decompress the pressure. So lateral canthotomy, cantholysis is the most important step we have to do before
so you
decompression.
do that even if you find it on table?
On table, yeah. So if you, so in this case, the site of leak is not the midline. It's close to the orbit. It's very dangerous. Once you are injured, try to control because we have a margin time of 30 to 60 minutes. It's not that immediately you're going to compromise the vision. So we have enough time to handle the blood, stop the bleeding, and then come out
But I think
and
the
see.
conventional teachings, if you see it on table, you go for a orbital decompression. If you see it in the posterior body, you go for lateral canthotomy.
I agree that. I agree that.
Because I had a patient, I think we are running short of time, let's skip that patient. So, any comments, because you just have 1 more minute, like 2 more minutes, any comments or any advice for the youngsters, a lot of postgraduate students are here, to avoid complications in their practice? Let us start from that end.
So the most important thing is CT. So the pre-op CT is very important, and we have to start from the anterior to posterior. Every part of the sinonasal cavity is important. You can start from the frontal sinus until the clivus. You have to see every abnormal anatomy or the anatomical variations. This is very, very important to prevent the complications. Can I go for the in detail or just?
Only one comment from.
So the CT is very, very important. That is my.
Right.
A thorough knowledge of anatomy is important, and you have to correlate with the CT scan. A CT scan should be good so that you can see every details properly. So you should have a road map before you do surgery. That is more important, prevent the complications.
And as Sundarak said, anatomy and radiology are very important. And one more tip I give you, when you pass endoscopy, anteriorly go laterally. When you go posteriorly, go medially. Nothing will happen. So you should not go laterally in posterior. So anteriorly when you go laterally, when you go posteriorly, go medially.
Yes, sir.
That's,
My comment is go for the landmarks. If you are not sure, stop. Then you are lost, and then complications come. Second comment is take your time. If you are in a rush, if you hurry, your wife is waiting at home, the anesthetist says, "How long, doctor?" It's not good. Take your time. This is quality.
That's really important. Quality needs, I take that golden word from you. Quality needs time. See, there's nothing big about being a fast surgeon. Do it slowly, meticulously. That's what makes you better.
So the visibility is more important. So first of all, when you start the surgery, you have to visualize all the normal anatomy, familiarize with the normal anatomy, because each and every patient has a different anatomical structure. It is more in recurrent cases. So familiarize with a particular patient's anatomy. Then you can go for use ancillary methods like intraoperative fluorescence to improve the visualization of the defect and pathology. That is also more important. So visibility is more important.
Thank you, sirs, for your expert comments and all your guidance. I think we are on time. Naren, you want to summarize this? Okay. So thank you, sir. Thank you. Thank you.
Thank you for the interactive session, sirs.